Now, if you look at what skin does to you, you know what will happen when you have burns. Skin takes care of the entire hydration that you have, the moisture that you have, which it is retaining inside. It provides you protection against the heat, the extreme cold, and also trauma. So it's a barrier which is present throughout. Don't look at this. This is just to complicate things. I'll make it simpler for you. So burns would be basically an injury to the largest organ in the body. The moment you get the skin off an individual, he will lose what all? Water. And what goes out with water? Electrolytes. Water doesn't live alone. It's like water is there, sodium is there, potassium is there. They all get lost alongside. So you will naturally have what? Dehydration. This is electrolytemia. It's a technical term for loss of electrolytes. Thirdly, it will also make you vulnerable to the rest of the world. So you'll get infections. And it will happen in the sequence as I am telling you. So naturally, first of all, what can kill a patient? The immediate trauma. Later on, loss of fluids, dehydration. Further later on, sepsis. So if you look at it, the percentage of patients dying of the third problem is relatively less because they would have died already. But when I say this, I may not be right for a burn which is minor. You burn your finger, you hear this term, I burnt my finger 5 times. So you don't die of it because the loss is less. Therefore, we needed to grade the burns. And this entire jiggery pokery is about finding out how much is the damage so that you can plan your repair. So one division is it superficial or deep? Now the deep, when he said, I asked him how deep is deep. So superficial can be just the epidermis. You just lose the epidermis, which happens very frequently. But the dermis would soon allow the epidermis to grow back. So this would settle down. But then deep can be many layers. It's not just one. So I'll divide it into superficial, it's epidermis with a bit of dermis. Then this is called grade 1. Grade 2 is dermis completely gone. A little bit of subcutaneous tissue. It can never be, it's not a surgical line. Grade 3, subcutaneous along with some bit of sheaths, tendon, etc. Grade 4 is all the way down, bone, periosteum, damaged. So naturally, before you talk about the depth of it, you'll also talk about its extent. Isn't that more important? If it happens only at one point, you won't die of it. You lose that organ. Say it's this finger, the finger goes. You don't die. But the same superficial burn, if it happens all across your body, you don't have epidermis anywhere in your body, you will die. So the degree of burns is not just dependent on the depth of it. It is also related to the surface area. Okay? This is a hand-drawn picture of what happens at a cellular level or at a tissue level. But before you go there, you should understand that it's not the story of sodium, potassium and water only. So when I have to teach you a clinical subject, I'll start with the patient because there's no point talking about something. It's like you learn all about GPS without having to go anywhere. Right? You guys learn about GPS, but if you have nowhere to go, you forget it. And you would remember, you recall your childhood, you'll have a competition amongst yourselves. Let's find out a country in a globe. At least we had it, I don't know, now it's changed. Where is Uganda? 2 minutes, you search around. We keep on competing. Where is big thin stain. You search, you don't find it. But we went nowhere. So naturally you will forget. But if I had gone there, I would remember. So therefore, surgical teaching is about knowing the living problem, not the dead solution. The living problem is the patient is sustained burns. There is a fire here. Now what are the various types of shocks that can happen? What are the various types of injuries that can happen? So it is not the skin alone that suffers. You inhale the smoke, then there are inhalational injuries. You die before you get burnt. Interesting? You die because of choking. Your respiration is gone. You keep counting the depth of the burns, but the patient would have died. So don't get confused with these gradings, stagings. They are just guidelines. Guideline is a direction. That okay, this is this degree, so the chances of damage are this much. It's an estimate. So when you have an earthquake, if your house is fallen in that earthquake, unfortunately, you won't be interested in the Richter scale. Because my house, well, it's a severe bad earthquake. Similarly, if somebody died of a burn, you keep calculating the depth of it. It won't work. So this is after you have seen the patient and after you've done something about his management. So let's take the management and I'll discuss physiology along with it, because only physiology or only management doesn't work. So what are the various kinds of shock you can get in a patient of burns? Who's going to answer that? Red shirt. You'll have to shout because it's a lot of noise.
Hypovolemic shock due to loss of urogenic shock, cardiac septic shock.
You're right. You've given me most of it. Maybe you don't remember the others. Next. And whoever doesn't know should say, I don't know. So
Cardiogenic shock.
you mentioned that. Or you didn't. Goes to your credit now. Fine. You didn't say it, you said it. Any other? Alright, you answered most of it. See, first, you want to add? Remember, the moment you, just imagine getting burned. Like when you teach somebody inflammation, you teach them color, red or whatever, roller, etc. all that. What does it mean? Inflammation. Your finger in a flame. Everything that happens is what happens in inflammation. What will happen? Pain, redness, edema. You'll remember. That's inflammation in the flame. Same thing here. As soon as you have somebody getting burned, pain is an intense, severe factor. So their patient can have neurogenic shock. That's usually the first shock. The neurogenic shock would be, patient would have just collapsed. The rest will continue to happen now. So one has to be careful of this shock being there in the first place. Then he mentioned about the hypovolemic shock, which is due to fluid loss. But even before that happens, what will happen if the cell is killed? All that it has will be released. And a very important substance that is released is called histamine. What? Can you repeat? Histamine. What does histamine do? You're saying it. Excellent. So the next shock is an anaphylactic shock. And therefore, if you have to manage it, you have to give what? Antihistaminics. I have not yet started with the rocket science. It's common sense. Now when the person sustains burns, what do you do first? Don't put a blanket on. It's the wrong thing to do, the do's and don'ts. Don't put ice packs. Why not ice packs? You can use normal water, but not ice packs. Can anybody answer that? Now there is no epidermis. And one thing I told you that skin does is control your temperature. You will have hypothermia. And a major killer in burns is hypothermia. Do you know that? You didn't know it, I'm telling you. Especially in cold countries. Because you lose tremendous amount of heat. And hypothermia kills. How does hypothermia kill? What does hypothermia do? No? Anybody? You are which semester? Six is reasonably. Yeah. What does hypothermia do to you? Second row? I don't teach monologues, they're not a part of my teaching. You have to be involved in it, otherwise there's no class. I don't waste time. I have better things to do than come here and read a PPT. I don't know. So give me the answer, I'll give you more answers. Yes. Bradycardia? Yes. And? So if I put it down simply, that it brings down your cryostat or it brings your BMR down, that would be a complete answer. And what does that do? It takes away your immunity. It causes
Enzymes. The enzymes, they stop
the
working.
enzymes stop functioning. Your protection is gone. You tend to have what? No immunity. And it also leads to acidosis because there is hypoxia with that. Cells don't function. So cellular hypoxia is actually shock. You don't have to read a lot of things about it. Shock is nothing but cellular hypoxia. All these types of shocks are the ways to get it. It can be cardiogenic, no blood reaching. It can be oligemic or hypovolemic, not enough blood to reach. It could be anaphylaxis, vasodilatation, so not enough blood there. Bigger vessel, less fluid. Same. It could be septicemic, which is a combination of all these and a sick cell. Hypoxia. So what kills you is hypoxia. Actually, in all diseases, end result is hypoxia. And which kind of a metabolism works in hypoxia? Not Krebs cycle, glycolysis. What's the end result of it? Lactic acid. That is acidosis we talk about. Every day you hear this. And what does acidosis do? You. Does nothing. Acidosis produces very important damage, very, very important factors. Therefore, MDF. What are those? Myocardium depressant factors, which lead to you die. So if I talk about an individual's death, I start by death of a cell. The cell dies and the organ dies and the person dies. So the death is the same. So understand this from a broader perspective. You will be able to understand burns better. Now, so I have a burn patient and these are the various types of shock. Anaphylaxis would present, I give you an example of a lady that came with a thermal burns, 60 degree. What is 60 degree? We'll discuss just now. She was 7 months pregnant. Unfortunately, these burn injuries happen to women more common, related to the domestic violence and also the dowry deaths, what have you. So, fortunately getting reduced, but it used to be rampant. Talk about here. The patient came to the casualty. The casualty used to be here, those days, not there, not any B, there was no building. The first thing that happened to her was she aborted. The histamine causes uterine complications. This is a presentation of burns only, but indirect presentation. So we would manage, say, a patient who has come with thermal burns on the spot first. So on the spot, take him away from the site of burn, otherwise he'll inhale. Say in this case, if you stay in this hall, you will have inhalation injury. Therefore, head and neck burns are considered very serious. Why? Because they compromise your airway. The other thing is inhalation injuries burn the entire respiratory tract lining, which leads to, again, laryngospasm, bronchospasm, hypoxia, death. Oligemia happens a little later because you have to lose for some time before you actually have hypovolemia. So in that order, neurogenic, anaphylaxis, even cardiogenic shock can happen here due to the reason I told you, but there are other reasons later. Finally, when the patient has arrived, you have to evaluate with this background. If you don't have this background, you do a mistake. What do you do with the burn patient? Suppose you are managing it. You want to make it cooler for him. Now, how do you make it cooler for him? Not ice packs, but running tap water. It should be clean. Running tap water will bring the temperature down, but not so down that there is hypothermia. You will take care of the anaphylaxis by giving anti-anaphylactic drugs. That is, adrenaline is when you have anaphylactic shock. You're right, and then adrenaline is the most powerful antihistaminic drug. There are many simpler ones, Avil, promethazine, etc. Anything, how does adrenaline work in anaphylaxis? Your answer is good, that's what I'm asking. Basically, it does three things. Exactly opposite to what histamine does. It causes bronchodilation, histamine causes bronchospasm. It stops the release of histamine from mast cells and reduces the peripheral pooling of blood, so corrects the hypotension. And thirdly, it is a steroid, so it is anti-inflammatory usually. Adrenaline is a steroid, it's produced in the body, it's a steroid. So we will take care of that, and now coming to the surgical intervention at this point. You can cover it with any clean cloth, but keep it cool. There are dressings available which you can apply. Again, it will depend on the degree of burns. Now, usually this is a background that Dr. Renuka must have already told you about. This is how it looks. If you divide the burnt area into various phases, there is a zone of hyperemia, then there is some bit of stasis and coagulation necrosis. Coagulation necrosis leads to the death of that tissue. Now, depending upon the depth of it can happen. It's a cross section of the same. I am giving you an example of a case. Zone of stasis looks like this. That is here. I can use my cursor, I think. And this is the zone of coagulation, and this is the zone of inflammation. This is how they look. And the normal scale looks like this. Well, this you don't need to know. I think I'll go to the calculation. Now, how do you calculate the extent of burns? There are various formula. You may not follow this. You may follow this. Totally depends on you. But the best is rule of 9. It's not here. But I'm going to use rule of 9 so that you understand easily. What did I say? Rule of 9. So, your 9. Keep calculating. Lower limbs, 18. It's front and back. Now you guys are used to
54. 50.
perineum is 1%.
55.
18 front, 18 back. How much is head and neck? Kitna bacha?
9.
So can you repeat it for me? Let me pick up somebody who needs a jolt to be woken up. Yes. Next to you. That's calculated. It's easy. And if it is easy, why should you make it more complicated? So forget this. There is also a method of calculating roughly. Your palm is 1%. Now, what is the problem with this? It will take long. What is the problem in using this? 1%, 1. Can anybody tell me?
Different sizes.
It's subjective. And to say that you will use patient's palm is impossible. So it will vary, whether it's your palm or Khalil's palm. Kali will measure it in 8 or 9 only. The whole body is done. Your calculation will go wrong. So palms are not good. The rule of 9 is the easiest and best to use. Now when do you say severe burns? Understand this, I'm talking about something very, very important. This rule doesn't apply to children. In children, I prefer to use palm because it is easier. So children should have some trouble with this system. Can you tell me what can be the trouble? The one in red. I'm hoping for an answer, that's why I've asked you. Percentage for percentage, should children do worse or better? What's the rule we use for the children?
So it's London Browder chart. So.
Speak loudly.
London Browder charts.
What is special about it?
So the body surface area, head has been given more percentage as compared to lower body.
Why?
Because they lose more heat to the head.
So, answered? You got it? Now, the other thing is there more surface area for their weight. They tend to lose more. So 15% and below that is safe in children, and 25% and above that, below that is safe for adults. Some people take 20%. So when I call it severe burn, I'm talking about a burn patient who should be admitted. So what are the indications for admission of these patients? Head and neck burns. I've already told you. All head and neck burns, doesn't matter what percentage, should be admitted. More than 15% and more than 20%. I said 25, call it good. Is that okay? Easy? Who should you admit? All of them. All the indications, 1, 2, 3.
Head and neck burns and more than 20% and more than 15%.
Done? Now, why should you admit them? Because you can they need admission to be managed aggressively. What is to be done at it? So we calculate the percentage of burns. Why is that important? That helps you calculate the amount of fluid to be given. That helps you calculate what? Now for that we have many formulas. The purpose of putting this chart is also the same. I have shown you what I have not taught you just now. So if you hear this, it doesn't strike like something you never heard of it. Modified Army-Brooks formula. This is the one I have used personally and I find that most useful. What is the Army-Brooks formula? Which formula do you know? Wallace's?
Wallace's rule
what
of
is
9.
It? No, Wallace's rule of 9 is done. Fluid.
It's a Parkland's formula. So.
So there is one Parkland, there is an Army-Brook, there is one
ATLS.
more. ATLS. So which of the three is most commonly used? Just because I am asking doesn't mean that it doesn't indicate that it's not related to you. So it's for you that I am asking through it.
Sir, ATLS, sir.
What is that?
So in ATLS, electric burns are given 4 times the body surface area into the daily requirement, but in the children are given 3 times, and adults only the multiplier is just 2.
No. So we'll go to the Army-Brooks formula. Easy. 4 ml, note it down, 4 ml into percentage of burns into weight in kg. So 4 into that much ml. Calculate for me the fluid requirement for a 50 kg person with 50% thermal burns and give it to me in 30 seconds. Now they're searching for the mobile. How much is it?
10 liters. 10 liters.
I've given this many times, so the answer is 10 liters, you're right. Can we stop there? Fine, great. Now, total fluid requirement in 24 hours is how much?
10 liters.
Louder? Everybody. That would mean some of you don't agree. How much is it? Green shirt. Stand up. Get some fresh air. How much is it? Say that. What's your problem? Does it take a lot of ATPs? Keep standing. So it's 10 liters in 24 hours. Now I'm going to tell you something which you'll repeat. How do you divide it in 24 hours now?
Half of it given in 8 hours.
So half of it, divide the day into 8 hours each. How many parts it is now? 3 parts. So the half of it will be given in first 8 hours. So how much will you give in first 8 hours? Very good. And the rest in 16 hours now. So you will be rushing it immediately. So this is the answer to how much. So how much do you give? I just told you.
5 liters of 48 hours. 5 liters makes 16.
Sit down. So 5 in 8 hours, and then rest 5 in 16. Clear? Now, what fluid to give? How much I've told you? The fluid of choice is Ringer's lactate. How do I choose it? I'm not talking about electrical burns. There was hardly any time left for that. So I can always teach you separately. Not you, you already answered. Yes, sir. The one next to you. So for 50 kg man with 50% burn, thermal burn, we have given how much? 10 liters. Ringer's lactate, and we select based on the pH. Ringer's lactate has a pH closest to blood. What is the pH of blood?
7.0.
Is that acidic or alkaline? Good. So that's closer to this. Secondly, it can be given fast. That is why we give it. So how much to give? Can you tell me quickly how much would be the fluid requirement for a 60% burn? I'm asking you again. Green. You can smile. Yeah, answer that. I gave you for 50%. You gave the answer. Can you calculate for it?
12 liters.
12 liters. For 70%.
14.
For 80%. Very good. Give a round of applause. I don't think I'm harassing you. I'm looking at some bright spots. Who answered it? But remember, I wanted you to do this mistake so that they all remember it forever. 50% and above, the fluid requirement does not change. You can't give a bucket full of fluid to patient. You can't just give it. Please sit down. So do you remember that? The upper limit is 50%. Beyond 50%, no. And this is the formula I wanted you to remember. It's visible. You all know it. And this is the palm formula which I taught you. And this is what you can do immediately. This is called tangential slicing of the burn wound and putting the graft. This is a skin graft measure. The picture is there, it may not be relevant to you. And this is how you can dress it with various things. If the burn is deep or superficial, how will the presentation differ? Superficial burn is extremely painful because nerve endings are exposed. Deep burn is not painful.
No windows.
That's how you pick up. When you have a very little burn, what is the best way to understand about burns? It can be wet or dry. Dry is burn, wet is scald. And the two have different management. Electrical burns, they have a totally different management. The picture is here. Electrical burns are deeper and farther than you think. Why? Because the burn would have happened inside not on the skin. The current traverses through the good conducting medium, and blood is one. So it will cause thrombosis or because of the damage to the intima far away from where the burn was. So they may lose more than you think. You may underestimate their extent. So therefore there is a different classification for electrical burns. You don't have to get into this. But all electrical burn patients, I have seen an electrical burn patient of 2% going by this formula on the left side dying of cardiac arrest because of the ventricular fibrillations. Left side is the heart and the current fluid. So they are different ball game altogether. So when all this physiology etc. is discussed, they only take into consideration the thermal burns, that to dry ones. Wet burns are worse. What are the clinical features of a deep burn? You would find either the vessels or the layers are exposed or they are blisters. The blisters indicate deeper burns. And if there is a blister, what are the do's and don'ts? Don't puncture it. It is sterile, you will infect it. It will rupture on its own with the dressings. So I have told you about the journal management. Pain management is very important. They need analgesia, but we avoid opiates. Why? Why not morphine? Very good, brilliant, very good. This is due to bronchospasm it produces. And you may also have one more reason. When you get burns, you may also fall. It will cause pinpoint pupil and you may miss the pupillary signs of head injury. Thirdly, it will produce unconsciousness. Your GCS score cannot be calculated because you drug them, so you can't calculate the GCS. You need to start on antibiotics to prevent septicemic shock. So the immediate causes are, I told you of death, I told you. Second week and third week onwards, septicemia sets. So septicemic shock comes in much later. So when you are asked about the management, start with the same ABCDE. Airway mandatory. In head and neck injury, burns, it will become very, very important. You may have to do even a tracheostomy, which is opening of the trachea. You may have to intubate the patients. You will have to give some antihistaminics, some inhalations to take care of what they have. They burn inside also. While they burn outside, they burn inside also. The cardiogenic shock can happen towards the latter part if the patient lives to have it. The other reason can be hypovolemia leading to cardiogenic shock, or histamine induced, which I have told you, or MDF induced or lactic acid induced, etc. Directly heart may not be affected. There was a picture which you saw in the beginning. If there are deep burns, here it looks clear. How do you know that? I don't normally like to show the PPD, but here then these pictures were more symbolic. Here, can you see this is the real case of burns here only, where there is an eschar formation. What is an eschar? It's not scar. E-S-C-H-A-R. What is that? Anybody? Now?
Dead tissue. Dead tissue, sir.
Dead tissue.
It's dead tissue, fibrous tissue.
More of fibrosis. So if it is happening around the chest wall, it will restrict the respiration. If it is happening in the limb, it will cause compartment syndrome. The blood supply to the distal part will be gone. If it is in the chest, you can see them release incisions have been given. This is called ascarotomy. Otomy means hold. If I remove it, it's called ascarectomy. So laparotomy is opening them down. Same. Craniotomy is opening the skull. Thoracotomy is opening the pulse. So it's opening. But here, just ascarotomy there. It's not dead skin. It's not dead tissue. It's fibrotic tissue. To release the chest so that you can breathe. Okay, time is, I think, ridiculously short for such a talk. And there is no point combining these integrations available. Can anybody tell me? Yes? Just because you're closer, that's why I asked you. You? Yes, green shirt. Red. You got to stand up anyway. Red means stand up. So, been to California University ever? I've been there. This t-shirt is not from there. I've delivered a talk there. I was visiting. Okay? So anyway, it doesn't matter. That was the lighter side. At least it made you smile. So what did I ask you? Dressings you know? Any dressings you know? Israel gauze is the dressing. We call it dry on wet dressing, old dressings, where they will stick a saline soaked red color, blue color, green color gauze piece, and then it will get stuck there. Third day they will remove it, and you will be howling away to glory, and you wouldn't want it to be removed. Okay? Till it starts stinking. It's obsolete now. Why? Because when you remove it, the thought was it will remove the slough. But the result is it takes away the granulation tissue also. So the wound never healed. And usually you will fight with the doctor, I'll remove it, you stay away, I'll remove it. Yes? And then you'll remove 1 centimeter and go for 2-3 hours here and there. Then 1 centimeter, then 5-6 hours somewhere. Because it would be painful. So the dressing has to be non-adherent, pain-free, antiseptic, moist. Repeat.
Non-adherent, antiseptic, pain-free, moist.
And now add freely available, antiseptic, which I think I have told you. Cost effective, not there, very expensive. So we have silver dressings, which have silver iron, which is supposed to promote healing. They claim so. But it's certainly not adherent, doesn't cause pain. They can swear by it, we use it. And once the wound is granulating, we put the best dressing. What is the best dressing? It is given in your book. Somebody said it. Joseph Lister, who was the father of antiseptic surgery. Skin is the best dressing. So, what is the best dressing? Skin. So, if you have lost skin, you need skin. How do you get skin? Graft. What is a graft? You take it from somewhere. You see the plant grafts? Take a stick, twig and put it somewhere. So when you detach it and refix it, that's a graft. When you do it to skin, it's skin graft. When you do it to bone, it's bone graft. When you do it to hair, hair grafting. This you know. Skin graft can be again, you mentioned about the burns, it can also be just epidermis, and epidermis and dermis both, split thickness, full thickness. What? Now split thickness is called Thier's graft. Can you repeat? Thiersch. And the full thickness is called wolf graft. But it's not the wolf, you know. It's the name of a surgeon. So he was not a wolf. It is WOLFE. Okay? So, split thickness, full thickness. What is even better is a flap. Flap is it is still attached to its blood supply and you just rotate it or you bring it from somewhere, or if it is based on a known vessel we call it axial flap. If it is on unknown vessel we call it random flap. So I have told you 5 things. Skin graft can be split thickness, full thickness. Split thickness is called Thier's graft, full thickness is called wolf graft. Flap is it is still attached to its blood supply. We have rotated it, it has all the layers. And it can be axial if you know the vessel. It can be random if you don't know the vessel. And if you are super smart, it is a free flap, which is you detach it with its blood supply, take it to the new place, re-anastomose the vessels, and actually will take a long time. It's called free flap. So this is all about skin cover. But skin cover for such an extensive burn is not available from the patient. When you do it from the patient, what do you call it?
Autologous.
Auto or homo?
Auto.
Auto. What is homo? Same species.
Same.
Allograft.
What is homograph? Autograft is homograph. Garmi. Your own. And you can have xenograft. Oh, this they all know. Which is the most favorite animal that is closest to humans? Can you be louder? It is a pig. See? Pig is closest to humans in that sense. We have used banana leaves, potato peel. They are just barriers, they are not skin. Same as porcine graft. Porcine is pig. And now we are culturing the skin. That's called CEA graft. It's not CAA. CAA agitation was different. CEA is a different culture, epidermal allograft, something like that. They take out a part of the skin from the individual and then they culture in the lab, and they create a skin patch. It's available, it's done here also. In these patients, you need that kind of a graft. But what will be the deficiency? It's not grown in wild. It's like you put your pet dog in the forest, it will die the next day because it's not used to hunting. Similarly here, the skin is killing all the scavengers all the time. This one is not prepared for it. So the skin gets eaten off by the bacteria. So it's not a very good option, but if you don't have an option, you can get it across the counter. You can get plenty of it. Artificial skin is available. Is that okay? So, surgical part I've explained to you. It is fascinating to manage such patients. There's more to it. We can spend hours talking about it. But this is more than enough for you to absorb and remember. Is there any question? Anyone? Any questions so far? That's